Welcome to the NEI podcast. In this episode, we present a series of extended Q&A sessions recorded at the 2025 NEI Spring Congress in Philadelphia, Pennsylvania. Faculty members who presented at the Congress will respond to unanswered questions from selected presentations. Stay tuned for insightful discussions.
Hello and welcome. My name is Dr. Andy Cutler, and I'll be answering your questions about my presentation, All the Tea on ADHD, Guidance for Developing Effective Treatment Strategies for Patients with ADHD. Well, let's get started. First question is, what are effective strategies for differentiating ADHD from similar symptoms caused by PTSD, major depression, etc.? That's a terrific question, and the fact is that many of our diagnoses do have overlapping symptoms. One of the things you want to do is not so much focus on the overlapping symptoms, but the non-overlapping symptoms. So really understanding the diagnostic criteria from DSM and looking for things that are in addition to the overlapping symptoms. For instance, with PTSD, you might have distractibility, difficulty sleeping, difficulty paying attention, and so on. But with PTSD, of course, there's very strict criteria that you have to have a lot of symptoms of overarousal and avoidance and other kinds of things. Whereas with ADHD, of course, we have a strict set of 18 symptoms, 9 inattention, 9 hyperactivity, impulsivity, and you have to have at least 5 if you're an adult or 6 if you're a child of one or both of those categories. But also, of course, we have to have distress or impairment really caused by those symptoms. ADHD also is something that needs to be present in more than one environment. So these are some of the things. Now, of course, it is very unusual to have a patient with ADHD who only has ADHD. So it is certainly possible to have more than one condition, and then you need to, of course, address those comorbid conditions in your treatment plan. Now, we do have some medications that may treat more than one condition. For instance, viloxazine extended release. Viloxazine is clearly demonstrated to be an effective antidepressant, and it can treat anxiety, and it is FDA approved in the U.S. to treat ADHD. The two most common comorbidities with ADHD in adults are depression and anxiety. So, for instance, that's an example of using a treatment that might address more than one condition. Obviously, we're also going to use non-pharmacologic treatments, including various forms of psychotherapy, lifestyle modifications, even some forms of neuromodulation. All right, have you found a significant prevalence of worsening symptoms in executive functioning of ADHD in adults who are starting to get older, let's say into their 50s and 60s? The answer is 100% yes. This is well documented. We actually know that there is an association of ADHD with later on cognitive impairment, including MCI and even dementia. Now, there's a confounder here, and that is the single highest genetic linkage with ADHD is obesity. Believe it or not, elevated BMI. And along with that, with ADHD comes increased risk of cardiovascular disease and diabetes, all of which have been associated with cognitive impairment and risk for subsequently developing MCI and dementias. So it's very important with adults with ADHD to, of course, appropriately treat the ADHD, but then also to work on diet, lifestyle interventions, exercise. Make sure that if they have hypertension, for instance, it's being treated. Diabetes, similarly, look for smoking cessation, minimizing the use of street drugs and alcohol, and so on. So we really want to use all of these tools. And of course, let's not forget that it's very reasonable to use stimulants even in older adults, even with hypertension, as long as it is being addressed and treated and monitored. All right. I'm now seeing a lot of new female patients in their mid-30s to 40s with a previous questionable bipolar II diagnosis. They have poor sleep hygiene, irritability, impulsivity, low frustration tolerance, and they feel easily overwhelmed. Can you speak to whether this could be ADHD? Well, it could certainly be ADHD by itself, or it could be bipolar II with comorbid ADHD. We know there is a high comorbidity bidirectionally with bipolar and ADHD. For instance, approximately 30% of patients with bipolar disorder will meet full criteria for ADHD, and the rest of them, I am convinced, have elements of ADHD. Also, genetically, bipolar and ADHD travel in the same family, so family history may not be as informative. In other words, it doesn't breed pure. If you have ADHD, you could have a family member with bipolar and vice versa. They are both dopamine dysregulation problems, but you always want to ask yourself, how can I hurt the patient more? Well, you hurt the patient more if you give them a stimulant thinking they're ADHD and they actually have bipolar. So if you're absolutely not sure, treat the mood dysregulation first, ideally with a mood-stabilizing atypical antipsychotic that can help with depression, especially one that does not impair cognition. So, for instance, cariprazine is a very reasonable choice. And then look to see what's left. And if there is evidence of ADHD, once you've stabilized the mood, you can absolutely 100% treat the ADHD even with stimulants. There's abundant evidence now that if somebody is appropriately mood stabilized with a traditional mood stabilizer or an atypical antipsychotic, you can safely add stimulants and not make them worse. As a matter of fact, the data suggests you make them better, both cognition and mood. So this is a difficult, tricky diagnosis. Also, women, when they get into menopause, that's clearly been associated with worsening mood, instability, irritability, and also more cognitive impairment. So another thing to highly consider now is hormone replacement therapy, which must be initiated within 10 years of menopause for it to be effective. And this is obviously an area of active research. We need more information. What are your thoughts on the idea that ADHD in adults may be overdiagnosed given the nonspecific symptoms such as inattention, poor executive functioning, etc., that can be seen with other psychiatric diagnoses? Well, when people ask me, is ADHD overdiagnosed or underdiagnosed, I say yes. I believe it is happening in both directions. There's an awful lot of people. Some studies, older studies, say that approximately 80% of adults with ADHD are undiagnosed or untreated. It might be a little better than that now, but clearly the majority of them are not. And clearly we do have an issue with people seeking the ADHD diagnosis either as a socially acceptable diagnosis or explanation for their symptoms, or who are truly stimulant seeking. Both are real issues. So we really want to be careful and tease it out. Now, one trick I've used is I tell a patient, I am not going to diagnose you fully or start medication for ADHD in just one visit. It's going to take a couple visits. Now, those who are drug seeking will take off and go elsewhere because they want it right now. So that's one kind of trick you can use. But the other is I really do want to have a sort of a provisional diagnosis. Keep an open mind because as time goes on, more information comes in. Sometimes you ask a patient questions, they say no, and then they come back and say, I've been thinking about what you asked me and I really do have that symptom. Or I asked my partner or my spouse and they said, that really is an issue for you. And that brings up the point, it's always important to get collateral information as much as you can. Also, recognize what I said earlier, that there is an awful lot of comorbidity. And many of these symptoms, such as inattention, irritability, impulsivity, are transdiagnostic. You can see them with more than one condition. They are not by themselves diagnostic of one condition or another. There's many reasons. For instance, somebody has trouble paying attention or gets distracted. So you want to make sure that you're assessing for comorbidities as well. And you might have two completely valid diagnoses that have overlapping symptoms, and you have to take that into account in your treatment plan. Next, what are your thoughts on the concern of dopamine depletion on long-acting stimulants that some patients may have? And I have another related question. What do I do when my patient comes to me saying, help, my medication stopped working? Both of these are sort of related. I can tell you this. From my experience, there is a real thing that happens with stimulants. You dose optimize, you find the optimal dose, the patient is doing well, and after it's usually a couple of months, maybe 2-3 months, they come back and say, it just doesn't feel like it's working as well or lasting as long. That is not necessarily a patient who is drug seeking and trying to game you. I promise you there is a one-time thing that happens, and I don't know if it's pharmacokinetic, that their body gets more efficient at metabolizing or clearing the drug, or is it pharmacodynamic, that their brain chemistry adjusts and there's a tachyphylaxis. But what I find is it's a one-time thing where I increase the dose. And often I can get them back to where they were, and that's it. You go about your way. If that happens, however, you have to educate the patient that if you do interrupt your treatment for whatever reason, you run out of medicine, forget to get it refilled, you go on a summer drug holiday, whatever it is, do not pick up the old bottle of pills and start up at that higher dose again because your body will have readjusted. come back and see me, and we will retitrate or restart at the previous dose and work our way up. So I do believe that is a real phenomenon. Now, whether that's dopamine depletion or not, I'm not sure. But if we're using, this is another reason you want to use the extended release, not the immediate release preparation. And if the patient is using the medicine appropriately, and if you make sure that they're not using too many other concomitant things that could deplete dopamine, make sure to moderate their caffeine use, for example. I don't believe that there is serious dopamine depletion. That is something when you have abuse, usually. But you also want to make sure people have a good, healthy diet, because diet is the building blocks, obviously, for dopamine synthesis and so on. All right, let's see. How do VMAT2 inhibitors work differently than amphetamines, which I have learned also block VMAT2? So in one case, you increase synaptic dopamine. That would be with an amphetamine. In the other case, you're decreasing it with a VMAT2 inhibitor. Well, it is true that VMAT2 inhibitors and amphetamines both block VMAT2, but the difference is that amphetamines actually not only block the dopamine transporter, but as you push the dose, they flip it. So that now I've blocked VMAT2, so I'm not packaging the dopamine into a vesicle, and I have it floating free in the cytosol. And now I have flipped a transporter, which is going to pump it out, and I have plenty of dopamine available to pump out. Whereas with a VMAT2, I am just blocking VMAT2, and I am just decreasing the amount of dopamine packaged into the vesicle, so the dopamine floating in the cytosol is not being pumped out. And you have to rely on the vesicle being transported to the membrane, popping open, and whatever's in it releases, and it's going to be less. So I hope you understand it's not just the VMAT2 inhibition. Amphetamines do a whole lot more. All right. What are your thoughts on the use of venlafaxine for comorbid anxiety and ADHD symptoms? I think that's a very reasonable thing to do. We know that norepinephrine reuptake inhibition can be an effective treatment for ADHD. For instance, atomoxetine and viloxazine, extended release, both have that mechanism. Now, how can that work when we think we need not just norepinephrine, but dopamine? Well, in the prefrontal cortex, there are no dopamine transporters. Dopamine hitches a ride on the norepinephrine transporter, NET. So blocking NET in the prefrontal cortex increases both dopamine and norepinephrine, but guess what? Not in the ventral striatum or the nucleus accumbens, which is the pleasure center, so you don't get an increase of dopamine in the pleasure center, motivation, reward, where you're likely to develop addiction or euphoria. Now, the thing with venlafaxine, of most of the SNRIs actually at lower doses are more serotonin reuptake inhibitors. As you push the dose higher, you bring in more and more NRI. But I would say there's probably more effective ways to do that. For instance, atomoxetine has been shown by itself to help both ADHD and anxiety in some patients. Also, viloxazine extended release, which is a norepinephrine reuptake inhibitor that binds to 3 serotonin receptors, partial agonist at 5-HT2C, antagonist at 5-HT2B and 5-HT7. So that is a very effective antidepressant and anti-anxiety drug, as well as an effective ADHD drug. So other SNRIs are also reasonable. Duloxetine, for instance. Note there is a contraindication of using duloxetine with viloxazine because of a CYP1A2 interaction. But certainly those are some other strategies. You can use a stimulant plus an SSRI or even an SNRI at lower doses carefully. You can use a stimulant plus viloxazine. Okay, let's see. If serdexmethylphenidate, which is the methylphenidate prodrug, is Schedule 4, why isn't Jornay PM, since it has a 10-hour delayed action? That's an excellent question. In order to influence the scheduling, remember, scheduling is done by the DEA, not the FDA. You need to do a specific set of trials called Human Abuse Liability Studies, HALs, or